Afternoon, I'm Mike Wadman. This is Chad Vokoun. We're from Graduate Medical Education, the College of Medicine. And we're going to be presenting some innovations that are really driven by necessity for our graduate medical education programs. And they are developed, implemented, ran by our program directors, some of which are here. And so when we mention those, we'll have them raise their hands so you can know who to talk to if you're interested. First of all, necessity really means that we have new competencies and we have limited time. So our program directors are tasked with teaching these new competencies, assessing them, but really not giving any extra time. And so we don't want to take away from clinical experience to add more didactic time. We want to make better use of our didactic time. So the first couple are dedicated towards explaining those programs, and then Chad has a couple, depending on the bell schedule, if we get to those. But that'll be Chad's problem since I'm going first.
20 minutes for extra time.
All right, sounds good. The first thing that we're going to talk about is M&M and the way that programs have transformed M&M from morbidity and mortality to a quality conference. I think we've all experienced M&M and in the past really has looked at individual failings, opinions amongst faculty as to what the best treatment is that are really based on anecdotal evidence. We're trying to transition that from complex patient or rare diagnosis to complex systems, and maybe not a rare diagnosis, but systems problems that really are the root of the problem. There's a couple different ways to do that. One program, our ENT program, Barb Haywood developed this. There she is in the middle. Using general categories that could be applicable to any program. And so we're looking at the IOM measures of safety and quality. And then using ACGME competencies on the other axis and asking ourselves as we go through each of these patients, for patient care, was it safe? Was it timely? For medical knowledge, what do we need to know to take care of this patient? Going down the line for the IOM matrix. And using that to frame the conversation so that these M&M sessions, these quality conference sessions are standardized so that you go through it in a very standardized process and really based on evidence that really has the evidence behind it so that what you're teaching has the weight of evidence so that you're really providing quality care. Another way you can do this is our surgery program. Dr. Ari has run this, is looking at really more specialty specific measures. And so using the SCIP measures, Surgical Care Improvement Program, looking at those things that happen intraoperatively, postoperatively to measure care. And going through each case using those to frame the conversation and using those to really bring evidence to the care of these patients. And so moving away from the old conference of really looking at individual patients and failings on an individual level to looking at them from a system standpoint and having the entire group of residents learn from that. The next thing we'd like to talk about is rescue, which is really experiential learning for our residents. We talk about residents being present in the hospital more than any other group, seeing the things that are happening when it comes to quality and patient safety, and using that as a resource. Recent studies show that residents, if they receive their training at a hospital that really has high quality patient care, high quality outcomes, that's the way they practice when they're graduated. So along those lines, having them in a group that really addresses these problems, it's an educational group. They learn the principles of quality and patient safety, take that back to their programs, but also start to participate in the process of analyzing these problems, being integrated into the quality triads within the clinical units and starting to address problems, starting to address real issues that are arising within the medical center. Most recently, looking at physician order sets. Who knows those better than the residents? Their input's valuable in making those decisions. I'll turn it over to Chad.
The next kind of innovative thing that we've done, and this stemmed from my program in internal medicine and has actually kind of spread, is our direct assessment of resident handoff. So when we move from shift to shift, from our day shift to our night shift, we have an observation form, which you'll see here. It's hard to read, but it's just there for a placeholder, is where we have a faculty member go in and they watch our residents hand patients off and we actually assess them. These happen to link directly to some milestones within internal medicine that we're being asked to look at. And the interprofessional side of this, which Devin would appreciate, is that now the formal checkout sheet that lands in our EMR, that lands in the electronic medical record, that shows to-dos, plan of care, things to watch out for, contingency plans and such, is viewable by, we're piloting it currently on 2 floors, but the nurses can now view this. So we all think we have Epic on campus, but actually what we see, what the nurses see, what the anesthesia doctors see, everything's kind of different. And we had to open up a gateway for the nurses to see what are the residents talking about and what are they checking out. It's improved communication without even talking to each other, which we do less of with the EMR. But so we're directly evaluating our residents. This is linking to milestones, and it's also giving more formal time where a staff member is with our interns, with our young learners, and showing how to do that. Chris Smith within my department has really championed this, and he's also started to do different types of handoffs, such as from the ER up to the floor. We've talked with Gene Simonson about when our patients go to the OR and then come back, you know, and how we can really transition handoffs. And so this is something that I think is cool, and we're hoping to grow this across campus and across professions. The final thing that we want to talk about, and this is using Paul and Patty's simulation lab, is we do Code Blue simulation. We've done it for about 5 years. Dave Gannon, one of our critical care docs, and he usually involves 1 or 2 of his fellows, have set this up. And so every one of my residents go through Code Blue simulation down in the sim lab. This is very interdisciplinary and interprofessional. We have anesthesia or critical care docs there. We have respiratory therapy. We have pharmacy. We have the whole gamut, and we go in and they run Code Blues. And we kind of sign off on our residents saying, hopefully, the first one you run is in a simulation lab instead of on 5 West or something like that in the hospital. And I've gone and watched, and it is amazing, first of all, how it can change a resident's view on, I can really do this. I offered you $20, Linda, to give us a little more time. Howard threatened me with a blow dart, and I want to see Paul's vacation photos, to be honest. So this is very interdisciplinary, and it's worked, and it's great use of the sim lab, and has really helped ease our residents kind of transition into that supervisory role. So happy to talk more. Okay.